Last session of today is about to begin here. It's Concurrent Session 5A. I have the privilege of moderating that with Cameron Musayev and Volkmar Falk. Is Volkmar here still? If not, stay. And our first speaker is my co-founder of the International Society for Coronary Artery Surgery and dear friend of, 25 years, David Taggart. David has encyclopedic knowledge of the literature regarding comparisons of coronary bypass to multivessel stenting, and is going to answer the question, what do you say if your cardiologist asks you why is CABG better than PCI? Dr. Taggart.
Thank you, John. Thank you for a very kind introduction. So why is CABG better than PCI? I looked at this recently, and I wrote my first letter to the Lancet about this in 1992. So I've been at this for over 30 years. And the interesting thing is the answers never really changed, and I will show you why CABG remains better than PCI. I have no relevant conflicts of interest with this talk. So in the next 14 minutes, what I'd like to briefly do is cover the evidence basis for CABG versus medical therapy, CABG versus PCI for 3-vessel disease, with and without diabetes, and in patients with impaired ventricular function, and then the very thorny issue of CABG versus PCI in left main. We'll look at the fundamental differences of PCI and CABG and show why over 3 decades, despite significant technological advances in PCI, it still doesn't match the outcomes of CABG and is very unlikely to do so. And then if time permits, we'll look at some of the current guidelines and controversies about those. So this is a paper from Mario Godino looking at CABG versus medical therapy. They looked at 4 randomized trials, 2,500 patients. Now, although these trials are relatively dated, there was quite good use of optimal medical therapy, 80% of patients on aspirin, beta blockers and statins, plus some other medical therapy. And these patients were followed for a median of 5.5 years. Now, notice that most of them didn't actually have significant coronary artery disease. Only 2/3 had multivessel disease, and only 60% had proximal LAD disease. So these are not patients we would typically operate on. So nevertheless, if you look at what happened to these patients, you can see there's a survival advantage appears at 5 years, but importantly, it continues to accelerate out past 10 years. And that's very important because if you treat these patients properly, their anticipated life expectancy should be in the region of 20 years. If you look at the best evidence for 3-vessel coronary disease, PCI versus CABG, still the most definitive trial was a Syntax trial, published now 10 years ago. But what was important about Syntax compared to all the other previous trials was it was a relative all-comer trial. All the previous trials of PCI and CABG had been very highly selected. And in this cohort of around 1,000 randomized patients, what do we see? We see at 5 years a significant reduction in overall death, cardiac death, myocardial infarction, and need for repeat revascularization, and no difference in the incidence of stroke. But what's more important about this trial, if you look at the severity of coronary disease according to the Syntax scores, you can see that if you had a Syntax score below 23, the survival advantage of CABG at 5 years was 1%. But if you had intermediate disease, it was 7% at 5 years, and almost 10% for the patients with the highest Syntax scores. And remember, this is at 5 years, so a relatively early time point for these patients. And if you follow the Syntax trial out to 10 years, even although the overall score, mean Syntax score, was only 29, you can see there was a 40% difference in the hazard ratio for death at 10 years. And this is a paper by the great cardiologist Patrick Sorois looking at what happened in Syntax. Now, in Syntax, although it was a relative all-comer trial, in fact, only 59% of patients who were potentially eligible were entered into the randomized trial. 41% went to a registry because their coronary disease was so severe they were deemed not suitable for PCI. And what you can see is that the overall survival advantage in the randomized trial was around 4%. But as I've said, depending on the severity of your syntax score, it could be as high as 10%. But notice that the mortality for the patients in the registry, so those who were put in the registry because of the severity of the coronary artery disease, their survival was very similar to the trial patients. So in other words, once you've got severe coronary artery disease, the severity becomes irrelevant if you're going to do coronary bypass grafting, whereas for PCI, it makes an enormous difference. Now, the syntax trial, like many trials, has been heavily criticised, and the cardiologists didn't like the results of it, so they've done everything to overturn it. And the way they've said is you can forget about syntax. As they said, there were two fundamental problems with syntax. The first was it didn't use FFR-guided PCI, and it didn't use the best current generation of drug-eluting stents. So they conducted the FAME3 trial. This was a trial of around 1,500 patients where the PCI was now FFR-guided, and you used the best quality, newest drug-eluting stent. The primary endpoint was a composite of death, MI, stroke, and repeat revascularization. The trial was based on a non-inferiority outcome, and you can see that at 1 year, CABG was significantly better than PCI. Excuse me. If you look at the 3-year outcomes of this trial, what happened? Well, the cardiologists changed the outcome. They didn't like the fact that if you stuck to the primary endpoint, CABG remained significantly better and with an increasing divergence in results. So what they did was they dropped the primary endpoint of repeat revascularization. So they changed the outcome. And there were 40 authors in this paper. It was reviewed by statisticians, independent reviewers, and the editors. And has anyone in this room ever seen a randomized trial where the primary endpoint was changed at 3 years and still published? This shows you the pressure to distort what the best evidence shows, and we'll see that again with left main. So if you look at patients who are not diabetic, this is a paper by 14 senior interventional cardiologists showing CABG has significantly better outcomes with accelerating survival even at 5 years. If you look at patients with diabetes, then the benefit of CABG becomes even greater. And these cardiologists concluded in patients with diabetes and multivessel disease, CABG leads to lower all-cause mortality than drug-eluting stents in long-term follow-up. But I would also emphasize this underestimates the true benefit of CABG in patients with diabetes because these patients had relatively low severity coronary artery disease. They were not the patients you would see in routine practice. The authors also went on to dispel the myth that if you've got low severity coronary disease and diabetes, that you can consider PCI, and they stated very clearly CABG should be the preferred method of coronary revascularization regardless of the complexity of coronary artery disease. So it's not justifiable if you're at a meeting where the cardiologists say, this patient has diabetes but relatively low severity coronary disease, therefore PCI is indicated. The evidence shows that is not the case. And if you look at this paper from Steve Freem's group, looking at 8,000 propensity-matched patients with diabetes reflecting real coronary artery disease that you would see in normal practice, you can see this immense diverse outcome in favour of CABG, which continues to accelerate past 8 years. If you look at patients with ischemic cardiomyopathy, the STITCH trial showed a benefit of CABG that appears 3 to 4 years after the procedure and continues to accelerate out to 10 years. And Mark Crowell's group published this study of almost 5,000 patients with impaired ventricular function, ejection fraction below 35. Although not randomized, the patients were matched for 30 baseline characteristics, and they showed the same but an even greater effect than we saw in Stitch. And you can see that with CABG, as opposed to PCI, a marked reduction in the risk of mortality, marked reduction in MACE, myocardial infarction, the need for repeat revascularization, and no difference in the incidence of stroke. Now, some people have quite legitimately argued, well, what about PCI in patients with impaired ventricular function to reduce the risk of CABG? This is the REVIVE trial from the UK, 700 patients, ejection fraction below 35. It was PCI plus optimal medical therapy versus optimal medical therapy alone. And if you look at the outcomes at almost 4 years, there was no difference in the primary outcome for death, heart failure, repeat hospitalization, and no difference in the individual components of the secondary outcome, death, MI, hospitalization, repeat revascularization. So we can say that in contrast to CABG, there is no role for PCI in patients with impaired left ventricular function who need revascularization. I'll turn now to left main, because in 2008, I was one of the authors in this paper where we said, and this is going back to all the evidence that existed in the literature at that time, that CABG was the best therapy for left main disease. And it's very important to understand why. Up to 90% of patients with left main will also have concomitant multi-vessel disease, where CABG already offers a survival advantage independent of the presence of left main. And up to 90% of lesions for left main are distal bifurcation lesions and known to be at a far higher risk of restenosis. And this was confirmed in the outcome of the syntax trial for patients with left main. With syntax scores below 32, there was no difference between CABG and PCI. But if you had a syntax score above 33, which the majority of patients have with concomitant coronary disease, there was a strong survival benefit of CABG. And this was an important outcome because this definition of syntax scores above and below 33 was the entry criteria for the EXCEL trial. So if you look at what EXCEL showed, why is it important? Well, it's the most definitive trial of PCI and CABG in left main disease. I emphasize again, however, the patients were relatively selected with syntax scores below 33. 1,900 patients were randomized, although the initial randomization was for 2,600 patients, but the trial was stopped early without any clear communication of why. These patients had a mean age of 66, so an anticipated life expectancy of 15 to 20 years. The primary outcome was a composite of death, MI, and stroke, but not repeat revascularization, so different from all the other trials. And the authors used a new biochemical definition of MI, but did not include universal definition of MI, which was the standard and which was used in every other trial. Oxford was very committed to this trial. We were the second largest recruiters worldwide, our cardiologists and surgeons, because we thought this was a very important question. And I was privileged to be the chairman of the surgical committee of this trial. So what did EXCEL show us? It showed that at 5 years, a statistically and clinically important difference in the risk of death in these patients, young patients undergoing PCI versus CABG. It was accompanied by an increase in the risk of myocardial infarction and the need for repeat revascularization. And the editor of the New England Journal of Medicine initially wrote, "The finding of a higher mortality rate in one group than another in a clinical trial, unless the difference is clearly trivial, should receive central emphasis in the reporting of the results, and we would generally consider it important to include such information in the concluding statement in the final paragraph." So I agreed completely. I thought, this is right, this is what we need to do. But the paper was resubmitted about 2 weeks later with no changes, and suddenly the editor accepted it without any explanation. I thought that what this trial was doing was misleading to the public and potentially dangerous for patients. So although I was the chairman of the surgical committee, I then resigned. I withdrew my name from the publication. The other thing Excel did, and this again shows you the determination to try and overturn the results of what was a very good trial. If you had reported, as the protocol said, we would report both the new biochemical definition of MI plus the universal definition of MI. You can see that with the universal definition of MI, there was a far lower incidence of myocardial infarction in the CABBAGE group. So this would have completely overturned the way this trial was presented, and it would have stated CABBAGE is the superior therapy for patients with left main in this category. The other trial, the NOBLE trial, had patients with much less severe coronary disease, a mean syntax score of 22. They showed no difference in 5-year mortality, so consistent with the lower risk group in the syntax trial, but a marked improvement in CABBAGE in terms of reducing myocardial infarction, repeat revascularization, and interestingly, the PCI group had a higher incidence of stroke, and that was probably play of chance. Recently, the 10-year outcomes of this trial have been presented and showed, again, no difference in mortality at 10 years. But interestingly, we are still awaiting those data for the Excel trial. So in Excel, a rapid divergence in terms of mortality in favor of CABBAGE, but we haven't seen any 10-year data from the Excel trial, and I suspect we never will. So I'll finish on this slide. This is an old slide I've been showing for the best bit of 20 years, and it's not really changed. What are the 3 advantages of CABBAGE in comparison to PCI? And why do all the technological advances in PCI, why have they made no difference to clinical outcomes? The first is anatomically, atheroma is mainly in the proximal coronary arteries. So by placing your bypass grafts to the mid-coronary vessel, you don't only immediately treat the initial problem, but you offer prophylaxis against future disease. The second difference is the internal mammary artery, shown by Tom Lusher more than 3 decades ago. He was editor of the European Heart Journal, that if you place a mammary artery to the coronary circulation, it elutes nitric oxide into that circulation and therefore reduces the risk of further development of disease. And the third difference is that for most patients undergoing PCI, it means incomplete revascularization. And incomplete revascularization has been repeatedly and consistently shown to impair long-term survival and increase your risk of MACE. So on that point, I'm going to say, in my opinion, PCI is unlikely to ever match the results of CABBAGE for most patients with left main or multi-vessel disease. It didn't with balloon angioplasty, it didn't with bare metal stents, it didn't do so with the first generation of drug-eluting stents, and it hasn't done so with the most recent generation of drug-eluting stents. On that point, I think I've run out of time, so unfortunately I don't have time to go to guidelines, but I would like to thank the organisers for the opportunity to make this presentation, and of course you, the audience, for your attention. Thank you.
In the interest of time, we'll move on, but I do want to point out that I don't think there's anyone in the world that can give a more authoritative review of literature comparing CABBAGE and PCI than David.
Thank you. Thank you very much. We are going to our next speaker is Dr. Mario Gaudino. Dr. Gaudino, what do you say if your cardiologist asks, why don't you like FFR for CABG? Please.
So thank you again for the privilege of the podium. So let's say, what do I say if my cardiologist say why I don't like FFR for PCI? So let's start why cardiologists like FFR for PCI. It started several years ago. This was the original FAME trial comparing angiographically informed versus FFR informed PCI. You can see very clearly that there is a very early procedural separation of the curves in favor of functionally informed PCI, and then at a follow-up that in this case was a median of 2.5 years, there was no catch-up. So the result of PCI informed by functional testing are better than the result that PCI informed by anatomy, and this is because the early risk is substantially lower, and there is no catch-up. This has been confirmed in numerous other studies, and that's why cardiologists like PCI. What do we know about FFR for CABG? Well, not too much. There were two small randomized trials, Fargo and Graffiti. Those were trials where patients were assigned to receive anatomically informed or functionally informed CABG. The primary outcome was always graft patency at early follow-up. Both studies found no statistically significant difference between arms. Both trials were largely underpowered. There was a substantial percentage of crossover and protocol violation, but in essence, we essentially know nothing about the clinical effect of FFR-informed CABG. David has already shown that. We used FFR in a different way, and we use FFR to define the FFR cutoff for patency of arterial graft. We found it generally at 0.78 with some regional variation, and the arterial graft in this trial were mostly internal thoracic arteries. When reviewing the literature, you will find that the use of FFR does improve patency in those studies where the majority of the graft used as arterial graft. This effect is not seen, not surprisingly, when surgeons use venous graft. So if you want to decide if you want when to use, when to deploy your arterial graft, then probably using FFR is a good idea. How does FFR change the PCI versus CABG comparison? I think the best example is to compare the early curve of FAME3 and syntax. And I remember where FAME3 was designed, the idea was to do a modern and better syntax, to do a syntax where PCI was informed by functional information rather than anatomic information. And you can see the difference. See how in syntax there is an early accessories in a PCI arm, something that is interesting because we generally say, well, CABG has an early risk, a higher early risk as compared to PCI. Well, that's not the case. If you look at syntax, it's actually the other way around. But then when cardiologists started using FFR, this difference disappeared, and you see the early curve are essentially overlapping. But this is not surprising. In the PCI world, the risk for early procedural event are not patient factor. They are procedural factor. The number of vessels treated, the number of stents needed, the length on those stents. Those factors are the most important determinant of early outcome when you are doing PCI. So if you use less stent, you treat less vessel, your result are going to be better. But this is not true in surgery. This is the STS risk calculator. Where is the number of grafts? There's no number of grafts. Surgical risk is not based on the number of grafts that we deploy. So we need to be careful when we apply the same logic that the cardiologists are applying, because we just do a different job. And we know very well that when the complexity of coronary disease increase, the result of PCI get worse, not the result of CABG, because we are not sewing on the plaque, we sew distal to the plaque. So the complexity of coronary disease is really not as important in surgery as it is in PCI. So trying to minimize the extent of our intervention will not improve the early outcome of surgery in the same way that it does improve the outcome of PCI. Also, keep in mind that we are not operating on the same patient. Patients treated by PCI are different than patients treated by CABG. They have a much less aggressive form of coronary artery disease. When interventional cardiologists look at the fate of the deferred lesion, the lesion that were not treated because of the FFR evaluation, those lesions were mostly stable. When we did the same in the few CABG trial, that was not the case. There was a very clear progression of the deferred lesion. So the risk of not treating a lesion because of FFR information in surgical patient is much higher than the same risk when you are treating a PCI patient. So what do I think is the role of FFR for CABG? And I'm happy that Torsten is here because this is essentially what he has been saying for several years. We have to keep in mind that the mechanism of the two interventions are different. PCI treat the focal lesion. We provide, Torsten, surgical collaterals. And those surgical collateral prevent ischemic events that are due to plaque that are not hemodynamically significant at the time of the index operation. And those non-significant plaque are responsible for the majority of acute coronary events in our patient. It is the number of stenosis, not the number of significant or hemodynamically significant stenosis, that drive the outcome of patient with coronary artery disease. The strength of CAB is that it protects against the progression of plaque that are not yet significant when we perform our procedure. And it has been shown that those plaque, those so-called vulnerable plaque, are generally in the first 3 to 5 centimeters of coronary arteries. Our anastomoses are distal to that. That's why we can protect the patient against the progression of those stenosis. But if we inform our CABG strategy based on functional evaluation, we are giving up on this very important advantage. So that's why this is what I would say to a cardiologist that asks me why I don't like FFR for CABG. Because PCI results are dependent on disease complexity, and the easier you make the PCI procedure, the better will be your outcome. This is not true for PCI. And if we use an FFR-informed strategy, we risk giving away the most important strength of our operation, that is, again, protection against the disease of lesion, again, the progression of lesions that are not yet significant. Also, our patients are different than the patient that you see in the FAME trial. They have a much more aggressive form of coronary artery disease that progresses much faster. Keep that in mind. So yes, use FFR, but only to decide what type of graft you want to use, not which vessel you want to revascularize. And for your choice, my pets again.
Mario, this was an excellent and clear summary. I think it solves the issue. And certainly you bring the science and the understanding. That being said, there's also the practicality. We all get referred patients, especially the mixed surgeons. We get referred 80-year-olds, and they did an FFR of the circumflex, and it's 0.82. And hence, we get referred them for the tetrahydrolytic person as moderate COPD, moderate renal insufficiency. And you know what, despite what you said, sometimes our arms get twisted based on clinical gestalt to actually just ignore some of those lesions that don't have FR. But in general, what do you think of that?
Yeah, I mean, in the end, there is no, I cannot think of any information that is the only information on whom you build your grafting strategy. Is always a clinical call, right? And so in the patient you describe, which is an old, frail patient, probably a limited life expectancy, and you think a minimally invasive approach can benefit that patient much more than a complete anatomic revascularization? Totally fine, just do it. But I think we just have to understand that PCI and CABG are intrinsically different, and using the same approach to revascularization strategy with the two is intrinsically wrong, Mark. But then At the end of the day, we are clinician, not mathematician, right?
30?
Mr. Gardino, thank you very much. I find it personally a very difficult topic to handle in clinical practice for every individual patient, but I can imagine that you say that the benefit from cabbage is to protect for future atherosclerosis. But if we put a graft on a borderline severe stenosis vessel, and you see this publication where 30% occlusion rate sometimes after 1 year, how can an occluded vessel after 1 year protect progression of coronary disease 4 or 5 years later? And how should we manage those vessels? Should we put a vein graft on all non-stenosed vessels, or how does multi-arterial grafting fit into this? I find it really difficult from personally to
I'm not
comprehend all
aware
this.
of any publication that has ever shown what, if this is what you are saying, what is the progression of grafted coronary lesion in the current era. I do remember Burassa in 1975 showing that grafting a lesion at the time of, bypassing a lesion at the time of bypass surgery could accelerate the progression to occlusion of that lesion. But that was almost 50 years ago with, both surgical technique and secondary prevention strategy that are very different than the one that we use today. So I don't know what happened to moderate stenosis that are grafted. I challenge everybody in this room to show me those data. In terms, I agree, however, that for the surgical collateralization concept to be true, then you need a patent graft. I think that even Torsten would agree that an occluded graft is unlikely to protect against ischemic events. So then it's a question to just pick the right graft for the right target, and sometimes a venous graft is a much better and smarter choice than an arterial graft, especially maybe in a sequential configuration. So that would be my
For
answer.
example, I come from the center from Professor Pels, one of the initiating centers for the FAME study. We get these patients, they measure everything. And then we have a 78 is the lucky number always, 0.78 for the circumflex for the right, and if diffuse right, 0.78, going for cabbage. Then I think I put an arterial graft onto it, whatever happens to it. But if we have these kind of patients, sometimes I wonder if we just put a Lima to LAD and manage the rest of the lesions medically, are we doing a bad job? Because everybody says it's incomplete, but if they don't have the proximal LAD disease, we would first treat the RCA with diffuse 0.78 medically. So I find this bulk of information and data and FFR and long-term outcome arterial very difficult to bring together in a single patient.
Well, I don't think so.
That's hard, yeah.
I think in the case, I mean, if your FFR value is above 78%, you should put a vein on that artery, and the chances that your vein stay open are relatively good. And if it stay open, it will protect against progression of the disease. If your vein go down because of competitive flow, probably was not needed. So I don't think it's very difficult. I think it would be a mistake to put an artery on that lesion, but I think a vein is perfectly reasonable. If you don't want to graft that lesion, then you should not operate on that patient, in my opinion, or maybe do a minimal invasive Lima to LAD if it's a frail patient.
But I would argue, Mario and Ferdy, we don't know about independent arteriographs. That's an important distinction. Impact told us about composite arteriographs. So independent arteriographs might be different, whether they're pedicled or attached on the aorta. We don't have that 0.78 value.
Well, that's not true, Mark, because in impact, even though most grafts were Y graft, there were also in situ graft, and there was no clear difference between the two. The numbers were not very high, but yeah, but I think I mean we didn't see any large signal.
Hi, Mario. Bill Fearon from Stanford. Very nice talk and a beautiful summary of the data. and I agree with your assessment. I just have one question. There's one area where I do think FFR is useful for deciding whether or not to, in my case, refer a patient to my surgical colleague for bypass, and that's the LAD. I mean, I think if you have a borderline or negative FFR in the LAD, I'm not going to think, I'm going to think more about maybe PCI or medical management, because, you know, the limit of the LAD, I think, is the key to the benefit, in my opinion, to bypass in most cases. And so I really want to make sure that the LAD is significant. I don't know, I wonder what your thoughts are about that.
Yeah, so first of all, do we have all the FAME trial center in the room asking questions? but having said that, you're right. Even though we don't know what is the cut-off for ITA patency on the LAD, anecdotal experience would suggest that it is actually higher than in the non-LAD circulation. We generally know as a surgeon that the eta to LAD can quote-unquote tolerate pretty high degree of competitive flow, probably is because of the very large runoff. So we don't really, I don't think you can use that 0.78 of the impact trial and also apply it to the LAD. But I agree with you that if you have to study one vessel with functional evaluation, that's definitely the LAD.
Mario, another massive presentation. The older I get, the less I think I know. And I think that I would like to make two statements. Number one is, even with physiologically significant lesions, FFR, right, at rest, there's going to be competitive flow with the graft that you're going to place on that target vessel. So that's number one. Number two is, you know, there's the emerging, that John was talking about, coronary CTAs. And then there is this emerging new topic about lesion-specific FFR and vessel-specific FFR, right? So if you have a lesion that's, let's say, 50%, that FFR may drop across that lesion to about, let's say, 0.5, or let's say 0.8. But if you go further down the road, down the vessel, right, that FFR is going to go down, down, and down, and down. And I'm just wondering whether that is going to be a more critically important for us to follow as surgeons, rather than the current FFR methodology. Now, there's also false positives and false negatives, right? You need to have an intact microcirculation, and if that microcirculation is altered, diabetics, vessel disease that's very, very severe, the FFR may not be an accurate estimate of what goes on in the epicardial vessels.
No, that's a great point. Clearly, I do not have the answer. I don't think anybody has the answer, but the new FFR and new methods for functional evaluation are definitely very important, give us more information. Last thing I want to say, despite everything I say, there is a paper in Lancet that is going to come out very soon that actually support the use of functionally informed surgical coronary revascularization in a specific group of patients. So I think this is still a topic that will see a lot of debate.
So Dr. Ruel has to go on, and come to the podium now is Dr. Torregrossa, who is our program chair and just back from Philadelphia. Can we have a round of applause for his hard work?
Thank you. Thank you so much. I wanted to post the picture. The patient is sitting up in a chair, is extubated in the operating room, is sitting up in a chair. His flow final was 80 when we released the stabilizer, so he's doing very well. Thank you again. I mean, it's good to show, because we are here together, to advance the field together. You know, it's tough, it's never easy. It was my first live in front of colleagues, senior mentors, and it is good to try to push the envelope together. We are here to really show what coronary surgery can be. And in this sense, let's get inspired by the next talk of another program director who helped us to put together this outstanding meeting, Dr. Thors Dunst. And in this session of what do you say if your cardiologist asks why, he will speak about why do you need ischemia testing for decision making. Perfect.
Yeah, thank you, Gianluca, and congrats again to the great case. And so, Chairman, ladies and gentlemen, so why do you need it? I give you the short, direct, and German answer. It's I don't. And since we're not in time, and since we're not sort of stressed so much in time, I can go on, and I'll tell you why am I saying this. So what are we looking for when we test for ischemia? So you should all think about that, and I hope you agree when I say it's probably areas of malperfusion, okay? Everybody agrees? Okay. So what does it mean if, for instance, 20% of the myocardium is ischemic? What does that mean? Does that mean, like, can I say 1/5 of the myocardium is not adequately supplied with blood? I mean, this is what they call jeopardized myocardium, right? Okay, so anybody disagrees? Okay. So why do we revascularize? I think the idea is to improve blood supply and treat or eliminate ischemia, right? Everybody still on board? Everybody agrees still? Okay. So if revascularization improves blood supply and eliminates ischemia, the question is, how urgent should it be done then? I mean, do we need to operate right away if we detect it, or do we have time? Okay, so this is the data that you see from the imaging experts, okay? So whether they test for hibernation here with PET scanning, or whether this is a larger study here with SPECT imaging, they find that the higher the ischemic the myocardium at risk here, the jeopardized myocardium, the greater the difference in terms of survival or mortality, however you want to put it, compared to medical therapy. So the more ischemic, the more the revascularization works, right? So that's it. This is what the guidelines say. The guidelines say, detect the presence and extent of myocardial ischemia and guide therapeutic decision-making. That's it. That's your guidelines here in the US. And this is the outcomes that you get, again, from the imaging experts. You have jeopardized myocardium. The more you have, the worse is your survival. And if you have here medically treated patients, no jeopardized myocardium, this is the green thing up, I think at the top here. If you have jeopardized myocardium, that's the survival. If you successfully eliminate the ischemia by revascularization, that's your survival that goes up. So that's it. Okay? So your ischemia does it. That's the reason why we do what we do. Everybody agrees? Okay. How does this fit? You've seen it, ischemia. We have documented ischemia. We have no impact on survival in a randomized trial. You know, I would argue you could have eliminated that trial because 15 years before, Courage showed the same thing. No difference in survival. But you treat symptoms. You've seen this picture before. Greg Stone showed it, right? So there's less ischemia. So the question for me is, what do we actually do when we test for ischemia? Do we test for ischemia at rest or on exertion? We do stress tests, right? And stress tests test for inducible ischemia. So what do we do? What do we do if we have acute ischemia? Anybody doing a stress test in an acute coronary syndrome? Anybody who does it, please raise your hand. Okay, nobody tests stress or does stress tests in acute ischemia, so we all do it in chronic ischemia, and then we test inducible ischemia, okay? So then the question is, how dangerous is inducible ischemia? Well, ischemia, the trial says it's not that dangerous because obviously you can wait up to 5 years and not have a lethal event. All right? You treat symptoms. So how dangerous is inducible ischemia in patients that have impaired ventricular function? revived, they also had documented inducible ischemia before. That was the entry criterion. They needed to have that. And again, no difference, not even in rehospitalization. Completely neutral. So, how many complications do you know from stress testing? We subject patients by stress to induce their inducible ischemia by the millions worldwide every year, over the years. How many complications do you know? Does anybody know one? Almost none. I mean, the almost is for the one case that one person raises their hand, but I think somebody may have an acute event right now, and that is the same rate or the same chance. It may happen at a stress test, right? Okay. So now let me spin off. We had the peripheral vascular disease issue earlier, but now if you have a patient that has peripheral vascular disease and he has claudication, I would suggest that's inducible ischemia, right, when he walks into it. So what do we tell these patients as a treatment option? We say, walk into your pain. And why do we say this? It's even in the guidelines. I spared you in showing this, but it's in the guidelines. It says you have to do this. Why? To induce collateral growth, right? Would you suggest to your chronic coronary syndrome patients to walk into his or her pain, into the angina? Anybody here who would suggest that? I am. I'll show you why. If you look at the recommendations in the guideline, we recommend that patients with chronic coronary syndrome are supposed to exercise. And they're even supposed to do vigorous intensity physical activity. But they don't need to be checked for significant coronary artery disease. The degree of stenosis doesn't have to be clear at the time they get the recommendation for exercise. So I would argue that there will be a fraction of patients that have relevant coronary artery disease, maybe even to the degree that we think that that should be operated on. And they still do vigorous exercise. How dangerous is inducible ischemia? What do they do when they exercise and they get pain? Or they get dyspnea? They stop. And this trial may surprise you. It is a trial done in Leipzig, and one of the cardiologists in here actually works with us in Jena here, Sven Möbius-Winkler. So these guys did the following. They had patients that had coronary disease, and then they had an exercise protocol for them, and that was one, they didn't stent anything, and then the others, they randomized, like here 50 and 50, small group, but still, they'd randomized the other group to stenting. So stent versus vigorous exercise. Guess who won? Vigorous exercise did. So here, event-free survival after 12 months was significantly superior in the exercise training group. So how dangerous is inducible ischemia? So if inducible ischemia is not that dangerous and revascularization does not prolong life, why do we need stress testing? Revascularization does not prolong life. We know that from ischemia, courage, etc. And patients need to have symptoms in order to treat them invasively, whether you do, especially for PCI, right? And since you need to know for PCI and for CABG, you need to know the anatomy anyway. You need to have some sort of angiogram, whether it comes from a classic invasive one or from CT, doesn't really matter in the future, but you need to have that anatomic information. And that's why, now you know why I don't say I don't need any stress testing, because if the patient has symptoms, I know what I'm doing and I need the anatomy anyway, and I decide what I do based on the anatomy and not based on the ischemia that's present. Okay? And so this is actually something that the European guidelines have already sort of caught on to. I was in that group, and they had significant difficulties in dealing with these type of considerations because they, that sort of turned their world a little bit around. And so they said, as courage and ischemia selectively included only patients with functionally moderate or severe myocardial ischemia, but without any information on anatomical severity, it becomes harder to demonstrate a prognostic impact. So they try to sort of find ways around that. Maybe stress testing is still good. They still recommend it here in the thing, but they say the anatomical burden becomes the prominent prognostic factor. So what does that mean? And how do you explain this? We have a survival advantage with CABG. We have a survival advantage with CABG, not only over PCI, but also over medical therapy. And that is independent of your viability or ischemia status that you have. It always works. And here comes my favorite. This is the trial by Mario. Where is he? He left the room. He did this 20 years ago. He identified patients that had infarcted right coronary artery territories, right? So the posterior wall was basically dead. And then they randomized 200 patients, one in the group where the dead area got a graft, and the other one where they did not get a graft. And look at I marked it here. The one where there was no grafting had more rehospitalizations for heart failure and more clinically evident ventricular arrhythmias. So that graft still did something, even though it revascularized a dead territory. So why do we need ischemia testing for performing CABG? You don't? How do you explain the CABG effects? You need to think mechanistically. And you have, if you really want to know why, come to my talk tomorrow. Thank you very much.
Please, Dr. Nerad.
One group which all this data doesn't apply to is diabetics who do not get any symptoms, and you will see hundreds of them who appear with shortness of breath and they've already shot their ventricle. So I think that testing periodically, whether it's every year, every 2 years, 3 years, for diabetics who are at danger, I think should be recommended most definitely, because they don't have the mechanism. When you're saying if you have symptoms, why do you need a stress test? You're right about that.
That's right. So, I mean, this is, if you think about it, PCI and chronic coronary syndrome does not prolong life. So the only reason for it is symptomatic treatment. So you wait until patients are symptomatic and then you diagnose them, right? There's one caveat, and that is if you have a patient that really is not symptomatic, but still has relevant coronary disease. I mean, it's probably a small fraction, but it is possible that it's there, right? Now, in these cases, we need to have, in those cases, CABG has a prognostic impact. And that's why we need to make sure, and it's our job as the surgeons to make sure that these patients still get this chance. And so we have to detect them. And that's where the coronary CT angiography comes in. Because that, is as the primary detection, we need to be there and we need to detect those with high syntax scores in that. So basically, not with the syntax score is probably not a good score, but we have to have a surrogate for infarction risk, right? And then if you spin that question further, then you will end up with what is eventually the targets, or what are the targets that you graft, and then the competitive flow issue comes in and all that stuff. So if that concept that has to grow on you, but the more you think about it, the more you will understand why hybrid concepts make sense or can make sense, and why grafting a lesion that may not be flow relevant yet may still make sense, because if you have 50% chance that the graft stays patent And competitive flow is not a direct determinant of graft occlusion. It increases the chance, but it doesn't eliminate the ability for it to be open. So that's why you need to do this. And we live in a world, and Volkmar showed it this morning, we live in a world of individualized medicine, and we need to individualize our decision-making to every coronary surgeon, patient as well.
Dr. Taggart.
Thank you. Great talk, Torsten, as always. So 2 comments I'd make. The first is, in my experience, I give very little weight to symptoms or no symptoms. If the patient has symptoms better, it makes my decision easier. Over a 2-year period, I operated on 4 airline pilots who had all been picked up on ECG abnormalities as part of an annual testing, and all underwent angiogram, and they all had, as you've said, very severe burden of coronary disease, all of them completely asymptomatic.
Yeah.
And as Dr. Trahan said, I hate it personally when I'm an MDT and half of our patients, 40% of diabetes, and someone will say, oh, but the patient's asymptomatic, and you think, this is totally irrelevant if you have a high burden of coronary disease. The second thing is, if you look at PCI and CABG, and I don't want to anticipate your talk, because I'll definitely be there tomorrow, but one of the things we know from all the trials of PCI and CABG, as you follow these patients annually, there's an ever-increasing incidence of myocardial infarction in the patients who get PCI versus those who get CABG. So what CABG is doing is giving you a prophylactic benefit against future proximal coronary artery disease. And that's why I think it's remained as the best, mechanistically most important way to treat. But I do think it's very important to emphasize what is important is the burden of coronary artery disease. And the biggest killer in our society is ischemic heart disease. Why? Because for many patients, their first warning is also their last.
That's true. It's more than 50% of patients presenting with a heart attack have not seen a doctor before, have not been symptomatic before. It comes out of the blue. Over 50%. That's it. So, I mean, what you say is exactly correct. We treat with the prognostic idea in mind. And that's why symptoms are not relevant for us. We can operate despite the fact. And that's sort of the idea. And that's why we need to know the anatomy. The anatomical presentation is the most important part for our decision making. And then you have to do something that is technically perfect in order to have grafts that stay patent. And I'm always saying this one thing. You all know the radial artery and the ulnar artery. And I would argue, I mean, may not be perfect an example, but it's those 2 arteries have competitive flow. They're competing with each other because you can take one out and nothing happens most of the time, right? So do you know if competitive flow was a physiological problem? Wouldn't you know that there is a spontaneous ulnar or radial occlusion? The disease should be known. Have you ever heard of this? And if so, in other words, the guy who did this did a perfect job. So if we do a perfect job at grafting and, no kinks, no whatever, that may be one chance more. I don't think we'll ever get perfect, but we have to be really, really good at it. So thank you very much.
Very good.
Thank you, Torsten. We have our last speaker of the day, Professor Thomas Schwann. I mentioned earlier, Tom is presently engaged in an analysis of 2 million patients in the STS database. And I know that he's prohibited from revealing the details of that, but there isn't anyone more authoritative to give this a rebuttal. Why don't you always use arterial grafts if that's what the cardiologist asked you? And thank you all for being here at the end of the day. Dr. Schwann.
So thank you very much. Good evening, ladies and gentlemen. It's a pleasure to be here, and I have the dubious honor of following those luminary talks. It's going to be very difficult to follow that kind of a presentation. But anyway, so just to start, I have no disclosures, and just like Torsten said, this discussion would be a very brief discussion with our cardiologist because I almost always use arterial grafts and a short presentation. Thank you. Okay, I got 15 more minutes. Okay, so I do use arterial grafts almost routinely, and you can see here, this is my journey. I started my practice shortly after I finished my residency in 1994, and we started using multi-arterial grafts in the mid-1990s. In 1996, we used the radial artery in about 20% of our patients, and over the next 20 years or so, that utilization rate increased, such that by 2016, so 20 years after that, we were approximately at about 80%, and that has sort of plateaued over the last 10 years, and the rate of multi-arterial grafting in my practice in 2025 is 82%. I tend to believe that both beta grafting and radial artery grafting are complementary grafting techniques, and I try to tailor the operation to that patient. And I try to leverage the technical as well as the physiologic properties of both of these grafting strategies to maximize multi-arterial grafting utilization. I would also tell our hypothetical cardiologists that the enthusiasm for multi-arterial grafting, although it's lagging the world, is increasing in the United States, such that about 16% of our patients in 2023 had multi-arterial grafting. In my home state of Michigan, that rate is much significantly higher, at about 40%, and this is due to the initiatives of the Michigan Collaborative, which incentivizes multi-arterial grafting and has made that a benchmark of quality. And what's interesting is that this rate of multi-arterial grafting is increasing essentially across the full spectrum of demographics of CABG patients. So for example, in the elderly, that's at 27%, in the females, it's at 31%, in diabetics, 37%, and in the obese, it's 35%. But the question is, what should be the aspirational goal for us? Should it be the same as the LITA at 100%? And institutions such as mine, which have a 99.53%, are performing as expected. There are no guidelines or aspirational goals that are been put forward by our professional societies. And if we review the literature, in the case of beta, the rate of beta utilization in the published literature is fairly wide, between 1 and 64%. And the ART enrollment enrolled about 28% of those that were screened, so even that was a highly selective patient population. But the question is there such a thing as too much of a good thing? Is there too much of a case situation where multi-arterial bypass grafting is utilized? And I think that Mario alluded to this, and he published this study in an attempt to try to understand what happens when his group went from a 55% utilization rate of bilateral internal thoracic artery to try to utilize it routinely. And what he found, and his group found, was some challenges. So death increased, graft failure statistically significantly increased, sternal complications increased, and MACE increased. When we looked at the national practice patterns over 10 years in the STS database, we found that those centers that had a less than 5% utilization rate of beta had a significantly higher mortality rate, but similarly, those that had 40% utilization rate of beta also had a statistically higher significant mortality rate compared with single arterial bypass grafting. But this could be due to the fact that those institutions with that high beta rate use could have a low overall CABG volume with a small beta utilization, which comprised actually a large percentage of those, and it may be that these were essentially underutilized or inexperienced surgeons. So we repeated this data, and instead of using percentages as markers of experience with multi-arterial grafting, we used raw numbers of cases. And what we found is that both for beta and for radial artery, as the experience increased, there was no increased risk. As a matter of fact, the risk of perioperative outcomes of mortality and major morbidity actually declined with increasing beta experience and radial artery experience. So what do the current guidelines tell us? Unfortunately, they are not very specific. So in case of radial artery utilization, both the American and the European guidelines stipulate that the radial artery should be used only to highly diseased target vessels. In terms of the beta, the American guidelines state that they should be utilized by experienced surgeons in appropriate patients, whatever that means. And the European guidelines stipulate that beta should be utilized in patients with a relatively low risk of deep sternal wound infections. And I think that as we try to understand what is the best way to deploy multi-arterial grafting, we should separate what could not be utilized, i.e. they are absolute contraindications, and what should not be utilized, and those are relative contraindications. So let me go over this both for beta and radial to try to understand this a little bit better. So absolute contraindications for radial artery, obviously, if you do not have a radial artery that is usable, that's an absolute contraindication. And obviously, in those cases where you would have a compromise to the hand due to inadequate ulnar collateral flow, that would be an absolute contraindication. Now, what about the relative contraindications to radial artery utilization? If we review what's been published and what's in the literature, the relative contraindications are: 1, previously instrumented radial arteries; number 2, placing these to moderately stenosed coronary artery lesions; 3, limited surgeon and surgical group experience. And then there is also universal sort of acceptance that the radial artery should not be utilized in autoimmune syndromes such as scleroderma, rheumatoid arthritis, or vasculitis, or in vasospastic disease processes, although there is little or no experience in the published literature of anybody using the radial artery in those circumstances, so I will not refer to these. And let me just review the top 3 relative contraindications. So again, Mario on the forefront, he showed us that patients who've had a previously instrumented radial artery have significant endothelial dysfunction with subsequent abnormal vasomotor response, as evidenced here by flow-mediated vasodilatation. And this particularly seems to be prevalent in the first 30 to 40 days post-instrumentation of the radial artery. This is an interesting study that comes from us from Japan, which, again, small study, which looked at the early patency of instrumented radial arteries versus non-instrumented radial arteries. And you can see here that even in those patients who had an instrumented radial artery, the 30-day patency rate was approximately 80%, whereas those that were not instrumented had almost 100% patency rate. This is our own small study looking at the long-term durability of radial arteries that were instrumented, and they had significantly lower patency than those that were not instrumented. But what's interesting is that this study just came out of Australia, which looked at the fact at 2 groups of individuals, instrumented radial arteries and non-instrumented radial artery patients, and at 2 years there was no clinical difference, and in those patients who had radiographic follow-up, there was no difference at 4 years in terms of the graft patency of those that were instrumented versus those who were not instrumented. So now let me wade into this moderate lesion situation and kind of review what's available to us in the literature with the radial artery utilization in these kind of situations. Now again, because of the fact that the radial artery is a muscular artery and has a much more of a significant muscular element in the media, it is thought that the radial artery is at a higher risk of vasospasm and competitive flow. But again, as I said, we must understand that most grafts are subject to competitive flow at rest, even those which are physiologically significant. So this is James Satula's data, and he looked at the patency rate of internal thoracic arteries, radial arteries, and vein grafts when placed to moderate target stenosed vessels. And he found that the LETA was the best, radial artery was intermediate, and the vein graft was the worst under these circumstances. Why talk about the moderate stenosis? As we have heard, most of the lesions that are causing MIs and subsequent death are located in the proximal third of the coronary arteries, and they are not flow limited. So do we need a paradigm shift because we've been focusing on high stenotic lesions that are FFR positive? Do we need to focus now a little bit more on moderate lesions? And Joe Sabik has done a bunch of work in this, and what he has published is that he looked at the patency of the LETA versus saphenous vein grafts at 1 year and 10 years postoperatively, and what he found is that the LETA does decrease its patency with decreasing target vessel stenosis, but very, very slightly as the lesion in the target vessel decreases. What he also found was that the LETA was superior in patency versus vein graft at 1 to 2 years 1 in 10 years to the left-sided target vessels with moderate lesions. The one exception was in the right coronary artery distribution, where the vein graft was actually had a better patency at very low levels of target vessel stenosis. Now, he also published some data looking at what is the effect of grafting versus not grafting moderate lesions. And he found that if that moderate lesion was grafted, that was associated with an 11% lower mortality rate. And that lower mortality rate was driven essentially by a 22% lower mortality if that vessel was grafted with Aleta, but there was no difference if that moderate lesion was grafted or not grafted with a saphenous vein graft. And then the same group also came up with a new variable called a protection from myocardial ischemia. And he found that ETA grafts are associated with better ischemic protection than saphenous vein grafts. We do not have equivalent data on the radial artery, and so consequently, given the current status of the affairs, I would think that beta grafting is probably better in moderate target vessels with moderate degree of atherosclerotic plaque. So I will make one more point regarding moderate lesions. And today, most of the determinants that drive whether a lesion should be grafted or not grafted is essentially percent stenosis. And I will tell you, and I would like to share with you, that my perspective is that this is a little bit simplistic. So let's say that we have a 50% stenosis in a target vessel. And the question is, should we graft this with a 2 millimeter arterial graft? And let me give you two scenarios which I think are very, very different and maybe require two different understandings and two different management strategies. So suppose that this target vessel is 4 millimeters in diameter. With a 50% stenosis, that results in a 2 millimeter minimal luminal diameter. And if we place a 2 millimeter graft to that, probably there will be some competitive flow issues. On the other hand, that same 50% stenosis with a 2 millimeter target vessel with a minimal luminal diameter of 1 millimeter, placing a radial artery graft or an arterial graft to a 50% stenotic vessel probably will not be subject to competitive flow. So surgeon experience in radial artery grafting does matter. In centers with low experience in radial artery grafting, there was a statistically significant higher mortality compared to single arterial bypass grafting. And this is, again, in over 1 million people in the STS database. Moving out to beta, absolute contraindications, no internal thoracic arteries. Or number two, in the cases where patients need emergency or salvage surgery because there's simply not enough time to harvest bilateral mammary arteries. What about the relative contraindications? Well, we already heard that in patients who have an increased deep sternal wound infection risk, maybe beta is not such a good grafting strategy. And then number two, in patients who, or in surgeons' hands who have limited experience, beta may not be the appropriate grafting strategy. And finally, obviously, if you have bilateral subclavian artery disease, in situ beta is probably not reasonable, but free can be utilized. So let me just briefly finish and touch on these two initial contraindications that are relative. So again, this is our study looking at 1 million individual patients in the STS database, and we found that beta compared to single arterial bypass grafting carries a 2-time higher risk of deep sternal wound infections. And obviously in those circumstances, the radial artery does not devascularize the anterior chest wall, and there is no increased risk of wound infections. We also looked at the impact of skeletonization, and what we found is that as the number of risk factors for deep sternal wound infection increase, the risk of deep sternal wound infection rises exponentially, and that skeletonization mitigates the risk of deep sternal wound infections, but it does not eliminate it. And again, beta experience, just as in the case of the radial artery, also matters. And at institutions with low experience, less than 5%, there was a statistically significant higher risk of perioperative mortality associated with beta compared to single arterial bypass grafting. So in conclusion, multi-arterial grafting should be the default strategy in all CABG patients with deployment of beta, MABG, and radial artery MABG based on their unique complementary characteristics. Experience is important in both. Radial artery multi-arterial grafting probably should not be performed with instrumented radial arteries. In those situations, beta would be better. Radial artery probably should not be performed in moderate lesions. Probably beta is better. And beta should not be performed in high-risk deep sternal wound infections, and probably radial artery under these circumstances is better. But still, I would leave you with the fact that optimal graft strategy still is a science and an art. Thank you.
Fantastic presentation. Really, we have some question. Please.
I want to thank you very much. I want to ask you something about the moderate lesions, because the way I look at it, I find it difficult to interpret, because it suggests, like the coronary artery disease is really focal, that you have one place where the disease is 90% or 70 or 50% stenosis, but usually the patients we get have really diffused coronary artery disease.
Correct.
So when we do a measurement of the right with the 70%
Correct.
stenosis, FFR is 85,
Correct.
and when you don't see anything, it's 65.
Yeah.
So how do we treat the angiographically, the visual assessment and the FFR measurement when we look at high-grade, low-grade, moderate stenosis, and which graft to deploy in that vessel?
So just a couple of points. Number one, all the advantages that have been published regarding CABG and coronary artery disease are based on anatomic descriptions of the target vessels, right? None of them are based on FFR. So this is a new modality that's coming on board. Now, again, I have an interest in this new emerging technology of coronary CTA with analysis of plaque burden, myocardial blood flow, what's the plaque characterization. And what's interesting is actually there's been reports where there's no angiographically significant lesions in coronary arteries. But if you actually study the FFR along the entire vessel, it will decrease. And the question is why, and I don't think that we understand that. Again, FFR requires a functional and functioning microcirculation, and if that's not present, you may have a negative FFR, right? And again, even at vessels that have a low degree of FFR, right, or a high degree of FFR, at rest, there will be competitive flow. And I think that's why it is important not only to judge the deployment for moderate vessels just based on the percent stenosis, but the size of the target vessel and the size of the coronary graft that you're going to place on that.
But if we know from the earlier FAME studies that we cannot well assess visually the degree of stenosis, how can we make a judgment of our graft deployment if we cannot make a good functional assessment of the graft?
I guess I would tell you that I don't have the answer to this, right? And as I said, when I was standing in your position, right, the older I get, the less I know.
But we have some new tools, and Tom, you and I share a great interest in this new technology of high-resolution CCTA. The FFR measure that's done with a CAT scanner is cumulative. You saw those cartoons that were generated by AI that I showed earlier today. Notice that the colors change.
Right.
The further downstream the vessel you go, the numbers get worse because it sums the cumulative effect of each of those lesions, which is very different than the story you get from the cardiologist doing an invasive FFR. He or she measures what looks like visually like the tightest lesion and tells you that it's not focal. It's an FFR of 0.82. You don't need to bypass that. That same interventional cardiologist doesn't tell you that there are 4 other lesions adjacent that are 0.85 and that the sum downstream is 0.72. And so this is important, I think, and I think we're going to have better tools to make these decisions soon. And the tools will be CCTA and AI driven.
Maybe I can add some information to it. It may be a spoiler, it may be a teaser. But this is something for you to chew on, especially for you when you try to make sense of the stenosis degrees. Every paper that ever stated a survival advantage for CABG, and every signal that you see that in chronic coronary disease, whatever we do invasively, whenever there is a signal for better survival, there's always less myocardial infarctions in that treatment group.
Correct.
Okay? So that is the thing. So so what we do is we prevent future MIs. That's what people die from. And when we go and try to find a strategy then the relevance of flow is not important for picking the right target in terms of treatment effect, because the ideal patient gets grafts to every target that has, or every vessel that has some disease, so in order to prevent, to do do the extra blood supply. But if you have these extra, or the ideal patient gets all stented, if the stents wouldn't make problems, you could stent everything and be done with it. But that's not the case. So the reason why we need to have better tools and all this is we need to find the risk of infarction is the one thing, and then we need to find sort of the best strategy to have our grafts stay patent, and that's where the FFR may come in, and that's where your risk is changing, because if your FFR is low, the value is low, then your chance of the graft being patent is high. If your value is high, then the chance of your graft being patent is lower, but it's not zero. So that's why you have to have individualized decision-making on what do you do when.
But Torsten, even in those studies that Joe Sabik did, right, at 10 years, at a 50% lesion, the Lima was patent more than 90%.
Yes,
right?
That's what I'm saying.
So I think that, again, I think that we need to, I think in our calculus, look at the size of the target vessel, the size of the conduit, and then the percent stenosis. And I think those three elements are really important in trying to define how you're going to graft these folks.
Your point is excellent. It just has to be researched, and this is where research has to be done. We need to find out how do we get grafts patent when there is competitive flow. That is one of the, that could be a research project, or that could be a research area.
But isn't there competitive flow for all lesions? Because again, they are not ischemic when they are just at rest.
We have never approached our area, our field, from that perspective, and maybe it's time to do that.
Well, thank you so much. I think I love the sentence of more time we spend in the coronary field, the less we understand. I think that we are in a critical moment of changing of diagnostic element and technologies that will probably give us a way better understanding of how, when, and what type of graft we should deploy in our surgery. Thanks again for a great first day, and looking forward for tomorrow.
Thank you very much.